This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name's Joe Sam Robinson. It's my pleasure to have with us tonight, guess what? Another Joe Sam Robinson. So it's my son, Joey. It's great to have you here, Joey.
Good to be here.
And you've devoted yourself to sports medicine, is that right?
That's correct.
You know, it is pretty extraordinary to have the two of us here, two Joe Sams here on TV tonight.
What a treat.
That's right. You know, the evildoers are out there. They must be taking a step back tonight. Is that correct?
Yes.
Right. Well, having said that, let's talk a little bit about your career choice, sports medicine. What exactly is sports medicine? What is that?
Well, sports medicine, to be a little bit more precise, I do what's called primary care sports medicine or non-operative sports medicine. So this is a little bit different than what most people are familiar with the orthopedic surgery brand of sports medicine. What I deal with more is if you take the two facets of more musculoskeletal injuries and pains and you take the medical things, and if we were to look at a graph, if we could go to the first slide of all the injuries out there and put them underneath one graph like this, and if we could go to the next slide.
So this shows, just to discuss the graph a little bit, we see the sports injuries, and then this is all of the sports injuries there, is that right?
Yeah, that's just a little bell curve showing kind of, if you look over at the far right of the screen, it shows a more severe injury, and over to the left side of the screen on the x-axis, it shows a less severe injury.
So what you would be focusing on the ones that weren't injured so much, is that right?
Well, that depends. If we could go to the next slide. This graph is a little illustration of how one might manage the different sports injuries out there in musculoskeletal complaints. Most of these can be managed non-operatively, and then you have a kind of gray zone as they get more severe where they may need an operation, they may not. It depends on the patient activity level, how good a surgical candidate are they, how much does this bother them, and then you have injuries like an ACL and a 20-year-old.
Now what is an ACL?
An ACL is the anterior cruciate ligament. It's a very important ligament for stability in the knee.
So if that's injured, that's real bad?
It is.
Well, now, in looking at your graph here, it looks like most of the time surgery is not needed. Is that a fair statement?
That is correct, yeah.
And so it generally, under many circumstances, the best thing to do would be to be cautious and hope for just a recovery just with conservative treatment.
Well, it depends. I like to take my management to the individual patient, not just have a generic management for everything. And I take into account what the injury is, what the patient's activity level is. Is this injury preventing them from doing something they like, or is this just something that hurts them to raise their hand above their head, and they really only need to do it to get something out that they'd rather have their son get out of the cabinet.
Now, let's see, rotator cuff injuries, is that something that
I'm glad you bring that up. We'll discuss that a little bit later.
Okay, let's do that.
But let's, if we could go to the next slide and kind of talk a little bit more about what sports medicine does in general, and how, if we can make a little flow chart of how how we see patients.
And actually, a lot of people have sports injuries. Is that right? It's a very ubiquitous thing. Many elderly people, such as myself, are trying to climb mountains or pursue rafting experiences. So it's a pretty common thing in all age groups, really, is it not?
Absolutely.
Not just young people.
Absolutely.
Well, what does this graph show exactly?
So this just shows the kind of a general flow graph of what would happen if a patient came to see me in sports medicine. So number one, I pride myself on doing a good musculoskeletal history and exam on why the patient is here. So with that, I generally narrow down the process of what they have going on to a few different what we call differential diagnoses. And based on this, I'll either get an x-ray. Another thing that I do is what's called musculoskeletal ultrasound. So it's just like if you've, maybe not you, but someone out in the community, if they've had their womb looked at while they're pregnant, it's the same type of technology.
Well, it's probably not me, but
no.
You don't know these days, but
No.
I want to assert it would not be me. Well, keep going.
And I've had patients ask me if it's a boy or a girl on this as well.
Oh, really?
Yeah.
I see.
And so what this does is this is a powerful diagnostic modality that's not routinely used. It's a much cheaper imaging modality than doing something like an MRI. So
well, it's quite a difference in the cost, so that's a big deal out there. Isn't it? The whole country is riveted on how expensive healthcare is, and it's quite cheap, as we say. I mean, cheap means, but it's a pejorative word, but maybe it's not so expensive as other things. Any ideas on the cost on that? Percentage-wise on MRIs or something?
I don't know an exact cost because that goes through the insurance company, and there's a lot of different factors that have me about 3 steps removed from how much it costs the U.S. healthcare system. But suffice it to say, I can almost guarantee that it costs the country less to do a musculoskeletal ultrasound than an MRI study.
Now, the information harvest is pretty good, isn't it? I mean, when you do that, so could you see muscle tears or ligamentous injuries?
Absolutely. With rotator cuff tears, especially if I feel like the person's a more low demand activity patient, they might have had a chronic rotator cuff tear. We might put the ultrasound on the patient, have them do a provocative maneuver, and in about 30 seconds we have a diagnosis of a complete rotator cuff tear.
Now, what is a provocative maneuver? I mean, what would that be? I mean, just hold your arm
well,
up, or what is that exactly?
Well, for the patient, the most commonly injured rotator cuff tendon is the supraspinatus. So normally that hides underneath the acromion. So what I do is I have the patient put their hand in their back pocket, right there, so it brings the supraspinatus out. I put the ultrasound on their shoulder like this, and I have them abduct their elbow out against me, and that puts a little pressure on the supraspinatus tendon. And I've in people with complete rotator cuff tears, you can actually see the 2 edges come apart right there, and so we have a diagnosis, in the office before the patient even leaves to get, an MRI.
Now, would these heal by themselves? I mean, with the rotator cuff?
We'll get you.
Well, I missed it. Maybe Joey, my arm may hurt too. I may have a vested interest in checking on this, and maybe I'll get some free advice on the show tonight.
Well, I definitely will give you some free advice, but you'll just have to stay tuned.
All right, I'll just say, well, now, all right. What else?
Additionally, if I've done a limited musculoskeletal ultrasound over the area of interest based on what I think the diagnosis is to help make things more likely, help make things less likely. The other thing I do with the ultrasound is I use it to put medicines inside the area of interest very precisely.
Well, how would you do that? I mean, how would you do that?
So it depends on the area, but for the shoulder, for example, I put it on the glenohumeral joint in the back. I sterilely prep the area using the same chlorhexidine scrubs that are used in many operating rooms, and just put the needle straight down into the joint. So I'm able to visualize it going in there, and
so possibly we could, on the little TV show, maybe you could eject my shoulder. With that, of course, if they're timid of heart, they probably wouldn't want to watch it. Is that right?
We could
do it later off TV.
Yeah, the legal people may not like that.
No, that's right. But
I'll have you sign some forms.
All right, I'd be careful. Yeah. I won't be too litigious. Well, all right, just keep straightening me out, Joe.
Okay.
What else?
So if I believe for example, you brought up, injecting things. So if I think the shoulder arthritis is more of the issue, I might put some steroids and some lidocaine, which is a numbing agent, into the joint, re-examine the patient after completing the procedure. And if the pain's gone away, then I feel like I've got the diagnosis narrowed down to something occurring in the joint. And so depending on the patient, that might be arthritis, that might be a labral tear, or something else in the joint. So that allows me to number one, get the patient feeling better, and number two, get the diagnosis correct, and then we can go from there. And the other thing that I like to do for my patients is a lot of these conditions can be helped with strengthening or stretching certain muscles. So I usually give my patients some evidence-based home exercises to do and go over the exercises with them as well. And then I basically assess how the patient feels like they're going to do with those, and if the patient feels like they need some more help with that, I might send them to physical therapy to get some help with that, and then I might have them come back and see me. And if we go to that judgment zone on the graph, if we can switch back to the graph
well, let's
before.
do that. Let's take a look. There we go. Judgment.
If we get to that judgment zone and they've failed all these conservative things in the world that's still bothering them, some of those patients benefit from an operation. And if we can go 2 slides ahead, because I know you're just clamoring to talk about that rotator.
Is it rotator? Yes.
Rotator cuff.
Yes. Okay.
So you bring that up, and that's a very interesting
Well, the
topic.
over 60 age group, which I'm a member, this is not an uncommon problem.
It's very common. So the way we used to think about rotator cuff is we used to think of this as something like an open tibia fracture, an open femur fracture, where its condition alone on imaging was an indication to operate on it and fix it. And when we found that on imaging, we thought that was what we needed to do. As we've gone further and further, demographically, there are about 6 million adults in the United States above the age of 60 with a rotator cuff tear.
Really, they just walk the streets with this problem.
Absolutely, and those tears are a little bit more different than what you might see in a younger athlete with an acute tear. A lot of these are more degenerative tears, where they may not even be aware that the rotator cuff tendon is torn.
Is there any gender connection here? The ladies, often their bones are not quite as dense. They have a little osteoporosis. Does that carry over into the ligaments?
I'm not 100% sure on the likelihood with gender, but it does increase with age. If above or below the age of 40, it's very uncommon to see a rotator cuff tear. As you keep getting older, that chance increases dramatically.
Yes.
And so what's happened and
let's suppose I have a rotator cuff. I'm trying to cut to the chase here. And so you're going to say there's probably not that much chance that I would need surgery. How would you evaluate?
Well, it depends. So I like to see what the patient's biggest complaint is. From several studies they've looked at, and there's an ongoing study from the Moon Group, which is based out of Vanderbilt and includes other institutions like Ohio State University. They've looked at this because there's not a great correlation between rotator cuff pathology on imaging studies and how much the patient hurts.
Yes.
And often in cases, what we've been finding is that the patient is actually hurting from something else besides the rotator cuff.
Yes.
And so for patients, if pain is their biggest complaint, what I tell the patients is that they've got a rotator cuff tear, explain the diagnosis, and explain the non-operative course for this. Of patients that have this, about 75%, 80% of those people will do just fine with physical therapy. Physical therapy can take about 3 months before they start getting pain relief with this. And if they do get good relief with this physical therapy, it can last at least 2 years. And some of the early data coming out of the Moon Group studies has suggested that it can last 5 or more years relief as well with that. If the patient's biggest complaint is they're a high activity individual. So if you happen to be a neurosurgeon and you happen to be using that arm a lot,
Yes.
and you say, I can't lift my arm up like this,
Yes.
you might be in the group where I might say, we should think about maybe doing surgery. If you're saying I'm having trouble lifting my arm up like this, I can get by
Yes.
without the pain.
Yes. Well, now discussing pain, obviously there's a big abuse in opioids. So how would you manage the pain in these patients? I mean, what would you do? What would you suggest to them?
So if the person has a rotator cuff tear, what we can do is we can put some medicine with some steroids and some lidocaine right above the rotator cuff tendons. We talked
Yes.
about all the different options.
Right.
Putting the medicine right there to help calm down the inflammation in the area and allow the patient to have a little bit less pain.
Yes.
The other options in the first 3 months are we could do a trial of non-steroidal anti-inflammatories. We could try Tylenol at a little bit higher doses than what is given
Yes.
there. And the other thing that I bring up with my patients too is if you're above the age of 60, you've got a tear in your shoulder, you might have a little bit of degenerative arthritis. Your shoulder is not like it was when you were 20 playing sports, and
Yes.
you shouldn't expect it to operate at the same level. You're going to have some pain and discomfort, and doing other things like heat before you're doing your physical therapy, ice afterwards can actually bring about a great degree of relief, and that sticking with the program statistically will give a good degree of relief.
How about interference with sleep patterns? So sometimes rolling over and trying to sleep on one side, maybe it puts stress on the joint. Any comments? I mean, that seems to be, not to personalize this, but I've heard that sometimes is a problem.
Yeah. Or what about if it bothers you when you're doing your neurosurgical cases?
I think I do okay.
Yeah.
I'm still all right on that.
But yeah, that's definitely something that patients bring up, and we talk about things like using different sleep pillows, putting the patient in a good position to where they're less likely to roll over on their shoulder and cause the problem there.
Yes, yes. Well, good. I think we've been through the rotator cuff disease pretty well, and I'm ready for any other observations you might have.
We could talk a little bit about nerve entrapment syndrome. So if we go to the next slide, this is a guideline out of an anesthesia journal talking about. We could go through the whole thing, but for the audience out there, that ultrasound guidance for identification of peripheral nerves is a preferred modality and superior or equal to other imaging modalities out there. So, what exactly is a nerve entrapment syndrome, you might ask? If we go to the next slide, carpal tunnel syndrome is probably the classic nerve entrapment syndrome. That we have. Patients will describe some pain, numbness, and tingling in the first 3 digits of their hand. They might have some weakness, dropping objects, and that's due to the median nerve being entrapped in the carpal tunnel right here going through the wrist. What I do with this is depending on how bad their symptoms are bothering them, is either bracing them, giving them anti-inflammatories. The other thing that I do with the ultrasound machine is I will put some steroids and lidocaine right around the nerve so that it coats the nerve. It's as close to it as possible, and it'll push out those tissues that are compressing it right there.
Now, that seems to be a pretty big advantage, and rather than doing this blindly, which is occasionally done. So you're able to go exactly where you need to in doing this. Is that a pretty beneficial
Absolutely.
thing to do?
Most, the studies out there, there's a meta-analysis that, shows that the ultrasound-guided injection is superior to the anatomic guided injections. The long-term data isn't quite there yet, but I can tell you anecdotally, most of my patients do pretty good after these injections in the carpal tunnel.
Now, are there some dangers attached to this? I mean, presumably, if the needle is in the wrong place, you could really do some harm. Any comments?
Well, there's always with any intervention we do, there's risk and benefits of it, which I go over with my patients. But the big thing we worry about is damage to nearby structures. There's a modality on the ultrasound where I can see blood flow. So
Really?
Yeah. So I like to do that before I do these injections, and just knowing the anatomy to make sure that I don't hit any of the vasculature around there, and I make sure I find the median nerve. I'm good on my approach, and then I go in. And then my 2 rules I have for patients are, if they feel uncomfortable during the procedure, I tell them not to jerk while I'm doing the procedure because I don't want to hit anything I don't want to.
Well, that seems like good advice, right?
The other thing is I like my patients not to submerge the injection site into water for 24 to 48 hours. I don't have any good data on doing that, but I feel like it lessens the chance for infection slightly. And it's a very low risk to begin with, but I like that risk to be as low as possible.
Well, there are a lot of entrapped nerves out there.
Yeah.
I mean, and so this presumably this technology could be employed for ulnar nerve issues or
Absolutely.
in different kinds of things, and that would have the advantage of helping a patient avoid surgery. So the decompressive, that often is the case. That surgery is necessary, and when it occurs, sometimes the results are not as good as one would like. Is that a fair statement? Yeah.
Absolutely. And, this is something that I can do in my office, and about, meeting the patient, doing the injection, getting it set up, talking to him about the risk and benefits of this. This is under a half an hour ordeal, as opposed to separate meetings coming back to a surgical.
Is it very uncomfortable to have this done? Does it hurt much?
Well, I've not personally
Have you tried it on yourself?
I've not tried it
No.
on myself.
No.
I was thinking about doing that one time, but most patients don't have too much discomfort with it. I use the smallest gauge needle that we have in the office.
Yes.
I've used smaller ones in my fellowship training, but those are tougher to see, and I like seeing my needle at all times when I'm in the patient. And this works well not only for the carpal tunnel syndrome. I've done it in the elbow for cubital tunnel syndrome. I've done it in the ankle for tarsal tunnel syndrome. I've done it in the hip for myalgia parasitica, for lateral cutaneous femoral nerve entrapment.
Really?
Yeah.
I'll have to remember that.
Yeah.
That's a good thing. Well, the thing that I see is these entrapment syndromes that come to surgery. We have to give the patient every option to avoid that. So that sounds like a really useful thing to insert into the treatment of these problems.
Right.
Well, all right, Joey, do you have another comment?
Why don't we talk about some of the less classic, what you think of sports medicine, musculoskeletal care, and move on and talk about concussions for a little bit.
That's kind of up my alley. So well, why don't we discuss that? So
concussions are becoming a big problem. The news likes to sensationalize it. You can see on the slide, it's made a lot of covers of these various publications. And there's a lot we know about it. There's a lot we don't know about it. And the big elephant in the room is chronic traumatic encephalopathy that goes along with this. In the CNN slide, you can see right there the video they have playing. If you click on it, is for chronic traumatic encephalopathy for the video instead of what is a concussion. If we could go on to the next slide, please. So what I tell my patients a concussion is really a microstructural injury to the brain. We know it's an injury to the brain because the patients will come in with all sorts of different neurologic complaints like headaches, problems sleeping, mood changes, sensitivity to light and sound. And we know that it's in most cases microstructural because it's not detected on an imaging study. So usually if we do an imaging study like a CT, it's because we're worried about things like a bleed in the brain or a more catastrophic injury to the head. And the other thing that I tell my patients is it's a supply-demand issue with the brain being injured at first, and there's a large neurologic cascade that goes on acutely with the brain impact, and there's a release of potassium and some excitatory neurotransmitters, which causes an increase in demand for blood flow to the brain. However, because of the injury, the blood flow actually slows down acutely, and there's an increase in the calcium levels there that go down in about 1 to 2 days is when they start to do that. This slide that I've got up here is done from Dr. Giza out of UCLA, and this is data extrapolated from experiments in rats. We don't have the same data on humans because it's, of course, unethical to euthanize humans after a head injury and take a look at the slides of their brain. So this is probably about as good as we're going to do from a basic science point of view with concussion injuries right now. And usually this translates into clinical practice because as a state of rule, we like to hold our athletes out of any kind of activity for the first 48 hours as a rule and have them do kind of minimal schoolwork and things that bother them at that period. And then we will advance their activity starting with their schoolwork after that time. And then if we get down to the 10 to 14 day area, that's when the calcium dips a lot more on that graph, and that's when a lot of patients start to recover clinically from that injury.
So what would you do, Joey, if a person is playing football, they're hit on the head, and they're a little punchy afterwards? Would you send them back in? Would you hold them out? And then when do you sort of push the button to say you've had a concussion?
Well, it depends on their history clinical exam. Sometimes it's tough to tell. If I'm ever in doubt on a patient, I always recommend holding them out because it's far more dangerous to send someone in that you're not sure of than to hold them out. I don't like holding kids out of the state championship game or big athletic events. But there is something called second impact syndrome, which can be a fatal neurologic insult to the brain that we don't ever want to see. That happened up in where I did my fellowship in North Carolina, and it happened at one of the local high schools, and they introduced a law where we've got similar measures in Georgia about holding kids out that have suspected concussions and advocating for appropriate treatment with our students, athletes.
So getting back to school, you think maybe don't put, after a substantial concussion, be a little cautious about getting into the academic stress? Do you think that's might give people out a week or two to?
Well, it depends on the student athlete, but I always tell my student athletes, if you told them, you've got this problem, it might be tougher to study. A lot of them might say, well, it's tough for me to study, but I feel like I can go back out and play football. And I always make sure my kids go back and do their schoolwork before they're fully cleared for athletic activities. That being said, I've, from my training in North Carolina, I've brought down with me my academic accommodation forms for giving out to high school athletes. So if they are having, problems, they're able to do all their other classes fine, and their band class where there's a lot of loud noises and bright lights, that bothers them. I might hold them out of band class while they're recovering. And then if I see them back and they feel like they can do it, we might do a trial of letting them back in. Some students will have problems with bright lights and sounds, and I allow them to wear sunglasses and earplugs when they walk to and from class to be less provocative on their injured neural structures.
Probably you encounter the athletes are very anxious to get back to playing football, and they understate their injury. Is that a common problem there?
It is. However, I use the different tools at my disposal, talking to the parents as well, and they may have a very low symptom score, but we do some neurocognitive assessments when we see them in the office, and they oftentimes have less ability to fake being normal on those.
Yes.
And I sometimes will find patients that have no symptoms at all, but have some neurocognitive deficits, and I don't allow them to go back in.
You think the NFL is appropriately treating their players? I mean, that's kind of a provocative question, but there's a lot of issues about that.
That's a loaded question. I'm not.
You can dodge it if you wish.
I'm not an NFL doctor. At the last conference for the the AMSSM, Dr. Sills out of Vanderbilt, who heads one of the NFL committees on this, has briefly talked about all the next level stuff they're doing there. They're looking at helmets, and they're doing some next generation tests that are not available to the general public yet and are not fully worked out to try to improve our ability to treat athletes with concussions. Additionally, they've done some rule changes with limiting the ability to return the ball, where they've had increased injuries compared to other plays. And the one hot thing that came out last winter is this new blood test that's being developed, quote, for concussions. And what it does, it looks for two proteins that are released in the blood following a brain injury. Those are usually available, for you to sample from the blood about 20 minutes after the head injury. And the blood test is available in 4 to 5 hours. And this test is not really actually for detecting concussions. What this is really for is to say whether or not you need a CT scan for a more severe neural injury like a brain bleed or something that you need to get a CT for. So the real utility for that is to help you decide if you need a CT scan or not. It's got pretty good, not to go through the nitty-gritty statistics on this, but it's got pretty good positive predictive and negative predictive values for those.
Is that freely available? I mean, is that just in some locations that's attempted? It's not so common in Georgia.
That's not ready for prime time. There might be a few more academic centers in Georgia that might utilize that test, but it's not ready for prime time. And if we were to wave a magic wand and allow me to have access to it right now, I would very seldomly use that. Usually I feel if a patient needs a CT scan for decreased level of consciousness or worsening headaches or things of that sort, if that test told me I didn't need a CT, I'd be hard-pressed not to order a CT despite what the data shows.
That's reasonable. Well, what about, I'm trying to remember the days, of course, I've had several concussions in my time playing football, and one can wonder what would have happened without this subtle brain injury that I experienced as a young boy, but I'm a small joke there. But I can recollect the requirement to go back and play football would be, can you name the president? Is that enough? Just to say, in my day, if you knew the name of the president, you went back into play. That was about, and you could walk. That's the other important thing, you're able to move around. No. Any comments?
No, that's not. That's not sufficient in today's day and age. We have some forms out there called the SCAT-5 forms that are freely available on the internet for all athletic trainers to administer to the athletes out there if there are no physicians present. And those go through a variety of things. Number one, they start with, I believe they start with the Glasgow Coma Score, and these tests to help you decide, is this something really bad that might need to be sent to an ER tonight, or is this fall into more of the realm of a concussion injury that needs to be taken seriously but may not need to be rushed to the ER right there. Then they go through symptomatically how the athlete's feeling. Then they go through some more neurocognitive testing, asking them to memorize numbers and say them backwards, go through the months of the year backwards, and these things that might, they're designed to be a little bit tough to do to really put stress on the brain and see how well it's working.
I'm not sure I could do it myself now. Let's see the months backwards. Well, I a little joke there. But Another issue that happens, I think, is tinnitus after these injuries. Do you have any thoughts about that? The sense of ringing in the ears. Sometimes people comment about that.
I have had some patients with ringing in the ears, but I haven't seen anyone with prolonged.
Generally, it's a transitory thing.
Yeah.
Yes.
Yeah.
Well, good. Other comments? Other slides?
Well, I don't have any more slides, but as part of my sports medicine training, I do fairly more advanced management of medical issues with athletes for things like shortness of breath, chest pain. Part of my training was in sports cardiology. So if we were to look at an EKG, there's some normal findings that you see on people, and there's also some athletic changes that come along with being a good athlete, being able to run for a long time, and some adaptive changes that the heart undergoes. So I've had some extra training in how to read one of those with that in mind.
So in general, I think when people go through their physical prior to playing any kind of sports, I think they would routinely do something like this. And would it be routine to get an EKG on patients that are starting?
It would not be routine right now to obtain an EKG. While I was at East Carolina State University, all of our incoming athletes, including the mascots, received an EKG as part of their pre-participation physical.
Now, the mascot, they had pirates there. Was that the mascot?
They were the pirates.
They had the pirates.
Yeah.
Oh,
yeah.
So the mascot there, they were a political thing, and they wore the little hats, and they would run around to the football field,
Mm-hmm.
and they also had their EKG checked. Is that right?
Absolutely.
Yes.
And so, that brings to mind several issues. The hope in doing this is that you're going to find patients that are not having any symptoms at all and might have something like a hypertrophic cardiomyopathy that you could detect and have that appropriately treated. And
that's the sort of thing that might occur when a person was putting a lot of stress on their heart. Is that right?
Absolutely.
Right.
So it's they're particularly prone to that when they're dehydrated as well because of decreased preload to the heart, and they're exercising and decreased afterload. So you get a little bit increased risk of having a bad result with that with athletics.
So hydration turns out to be a big deal. Now, I was recollecting my earlier days as a young boy playing football, and the idea was you would toughen you up not to have enough to drink. So people became extremely thirsty. I can recollect players surreptitiously dropping down and drinking out of mud puddles. That sounds slightly apocryphal, but a true story. They were so thirsty, and the coaches wouldn't let them have sufficient fluids. But that's certainly not in evidence now.
No.
Is that right?
We've reversed that. There was a doctor down at the University of Florida, I believe his name was Dr. Cade, that got very interested in this. And of course, it makes sense now that football players might drop 10 pounds during practice in Florida in the summer, but they noticed, hey, they dropped 10 pounds. They didn't urinate at all. They didn't throw up. What happened to that? And of course, now we know that's all lost with sweat. And so what he did in his formulation of Gatorade is really, fluid follows salt. So what he did in Gatorade, and this is really what it is putting about as much salt in a fluid that you can stomach, and to do that, they put in a lot of sugar and nice tasting flavors to make it more palatable to the individual. But by doing that, you can pretty well expand your intravascular volume reserve just through oral rehydration therapy, as opposed to using something like an IV or more advanced measures.
So heat prostration is really not so common as it was in my day. I can certainly recollect stories of just the extraordinary dehydration that was occurring, and that's coaches and trainers are really on the lookout for that, and people get plenty of fluid. And
absolutely, I believe it's part of every athletic trainer's curriculum. We certainly learned a lot about it. We caution athletes that are on certain medications, like decongestants, ADHD medications that might make them more prone to heat illness, and to watch out for those signs and symptoms. Additionally, we talk with our athletes with sickle cell trait, that they might be more prone to heat illness. And
that's a good point,
yeah.
isn't it? Is that routinely known? I mean, there are a lot of Afro-American athletes in this part of the world. Is it known before they start doing their athletic, I guess, exercise that they have this? And is that the trait's not so easily distinguished sometimes? Is
well, it's now a part of the pre-participation physical, and getting an athlete to begin their college career, that has to be documented as being positive or negative. And if the athlete is positive for that, they have to receive education saying that they're more of a risk for heat illness, and the other things like splenic rupture at high altitudes than the average college athlete. And just with increased awareness.
Yes. Well, what about speculations on muscle tears? I mean, I can recollect in my day. Once again, I'm taking the audience back to 60, 70 years ago when I was a young boy. I'm joking slightly, not too much though, not too much of a joke. But muscle tears would happen. Running, pulled hamstring, very common. Is there any secret to recovery from that? I mean, with a really blue chip athlete that pulls a hamstring.
Well, with a pulled muscle or a partial tear, the thing we worry about is if the hamstring's pulled completely off the bone, it needs to be surgically attached pretty quickly. And usually we don't want to miss those because there's not a lot that can be done if it's off for a prolonged period of time. If a patient has a pull, what we call a pulled muscle or a small tear, frequently what we do is we do eccentric exercises. So what that means is if you're starting with a maximum contraction of your bicep and slowly going down like that, that's the eccentric form where you're lowering the muscle or going to its most relaxed state. There's a gentleman named Alfredson who pioneered this classically. This helps with tendon problems too, with Achilles tendonitis. He would load patients up and have them go from maximally contract and go down to their most stretched out portion of their muscle. And so 3 sets of 15 twice a day, I believe, is the regimen that was used there. And there was a lot of load placed on the Achilles tendon with that.
Well, what about the septuagenarian sportsmen such as myself here that might want to do something? I mean, do you really caution your older patients about how to avoid just musculoskeletal injuries or sports injuries, people that try and play tennis, that go up and down the Grand Canyon? I mean, whatever. I mean, what do you tell people about being cautious with an older body? I mean, warm up more, or what do you say?
Well, number one, they might be more prone to injuries, and number two, as you age, your probability of having something like cardiovascular disease goes up more and more. So, what I tell all my athletes, including the septuagenarians, is to start at a low, comfortable level. If I'm having them start exercise, I have them do what we call moderate cardiovascular activity. So how you'd advise someone on that is they can carry out a conversation when they're exercising, but they can't sing a song. And so the general recommendations for that, for getting cardiovascular activity, are 30 minutes, 5 days out of the week.
How vigorous is the cardiovascular activity? I mean,
so you can carry out a conversation, but not sing a song.
All right. So I
Yeah.
can't sing a song. That sounds like pretty substantial activity. I mean, would you agree? I mean, you
Right.
really your pulse rate is up to what, 100, at least 130, 140, some number like that.
Yeah, depends on age, and then from that, slowly increasing your activity, trying not to overdo it. And then if you do develop something like severe chest pain or something like that, that needs to be something that I know about.
Well, any comments on the obesity epidemic that we have? I mean, so it's sort of, presumably if you were more of a sports person, you would do something about this, doing something with calories, trying to diminish this. And many people have Fitbits I don't have any stock in Fitbit, but any comments on that? It's just you're trying to use your body to enjoy life and stay in shape, and is that a useful modality to be able to say you took 10,000 steps, or comments?
Well, when dealing with obesity, to lose the weight, what I tell patients is usually to lose the weight, diet is the most effective. So if you cut out 500 to 700 calories per day, that is usually good enough to get out about 1 to 2 pounds of weight loss per week.
Oh, that's a lot, isn't it?
It doesn't sound like a lot.
Is it hard to do?
Lifestyle changes of any sort are hard to do.
Yes, I mean the Apostat Center is so powerful, and many people are predisposed.
Right.
They have a genetic predisposition to put weight on, so that could be an issue. Well, what is a good sport? What do you think is a healthy activity? Walking, biking, going to the gym? What would you suggest for people as far as preserving their health?
It depends on the individual. I wish I put the slide up for this study, but basically the biggest intervention you can do to reduce your cardiovascular risk is going from nothing to going to a little bit. And then when you go from running, a 5K to a 10K, going from doing that to a half marathon, you get a little bit of a cardiovascular survival advantage, but it's less substantial than when you go from sitting on the couch to walking a little bit. What I tell my patients is to do something that they like to do and they'll be happy doing. I don't want them to do something just because it's better. But if they're willing to do anything, what I would recommend is a combination of moderate intensity cardiovascular exercise as well as some strength training, hitting more bigger muscle groups like the chest and glutes to maintain some muscle mass.
Weightlifting, any comments on that? Is that a useful thing? I mean, in moderation, can you hurt yourself lifting weights?
You can hurt yourself lifting weights. That's why I urge patients, if they haven't lifted weights, to make sure they contact someone at the gym that can supervise them lifting weights, work out with a trainer that can monitor them, or to look up some good form, because you can unfortunately hurt yourself lifting if you're not doing it correctly. And also you cannot get the benefit if you're lifting incorrectly as well.
Now, in Georgia, it's there are lots of high school athletics that are used here. I mean, do you have any comments about that, about how well the system is functioning for the students in high school, their athletic arrangements? Any comments about that?
Well, I'm a little less. I've just moved here from North Carolina and can't comment too much on the overall system here in the state of Georgia.
But it would appear, I mean, it seems that's where a lot of injuries could occur, and I'm sure there's a system in place to many dedicated people are in that to try and make things work better, and that I think that's a really useful thing to pursue. There are some tragedies that occasionally occur. I mean, we see them in young high school athletics. Sometimes can have very grievous injuries. I mean, we had a recent, case where there's a tragic death with a head injury. We sometimes see things like that, and that can be a very difficult situation. Well, Joey, it's been good talking to you tonight, and I have to say that Satan can back away. Having you in town here is great to see you back, and we look forward to talking to you some more. Thank you so much.
Yep,
Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.